Good afternoon, and big salute to Dr. Sanjay Kumar for organizing such a nice and informative event. And this is the 8th such Congress, and every year it has been a major success with magnificent lectures and innovative endoscopic things. I've been asked to cut short my talk because we are running late, so I'll try next 10 minutes to give a brief about infections and cirrhosis, how to manage and how to prevent. So I'd like to answer a few of the questions which are very relevant. Are the infections in cirrhotics a major challenge? Why infections are common in cirrhotic? Does it affect survival? What are the common infections seen in cirrhotics, and how to manage these infections, and can we prevent them? Though, yes, it is a common and serious complication among patients with cirrhosis. With advances in our armamentarium, major complications of cirrhosis like hepatorenal syndrome, GI bleed, hepatocellular carcinoma has shown a decrease in mortality and morbidity, but the sepsis and infection has increased, and so is their morbidity and mortality because of that. At every step of cirrhosis, the bacterial infection has a negative impact. If you look at the outdoor and indoor, the prevalence of infection among the indoor patients is about 37% vis-a-vis about 8% in patients coming in our OPD. And these infections are mostly in patients who present with GI bleed. About half of the hospitalized patients for acute decompensation of cirrhosis have infections at presentation, which was discussed by Dr. Akash in his presentations. If you look at the source of infections, so global studies suggest that 48% of these infections are community acquired, 26% are healthcare associated, and 26% are nosocomial. But Indian multicentric studies suggested that about 50% of healthcare associated infection, another 30% are hospital acquired, and only about 20% are community acquired infections. So this is the study done at 3 centers in India and 1 in US, where they have looked at what are the type of infections in cirrhotic. So obviously spontaneous bacterial peritonitis is the commonest infection, followed by pneumonia and urinary tract infection. Cellulitis is the least common, and the recent study from AIMS suggested that 45% of infection in cirrhotics are because of pneumonia, while our own study suggested that 20% of infections are from pneumonias. And the cause for the common infection in cirrhotic is because there is a decrease in innate immunity and other immune functions because of the cirrhosis. There is a reticuloendothelial dysfunction, normal gut flora are lost, there is a leaky gut with translocation of gut bacteria into the systemic circulation, there are bacterial overgrowth. All these things lead to an increased prevalence of infection among the cirrhotics. Does it affect survival? Yes, it definitely affects survival. There is a significantly increased mortality among the cirrhotic patient. These are all trials way back from 1993 to 2008. All suggest that patients of cirrhosis with infection have significantly high mortality as compared to patients who do not have one. This study from AIMS clearly suggests that those patients who do not have an infection have an increased survival as compared to those patients who has infection at admission or who develop infection within 48 hours of admission. The mortality is almost fourfold as compared to those who do not have infection. Patient having a 30-day mortality because of infection is 23% versus those who do not have infection, where the mortality is only about 2%. These patients have higher than overall rate of infection in hospitalized patients. Why the infections commonly seen are those which I have listed here, but I'll not go into detail. How do you suspect that this patient has got an infection? Presence of hypothermia or fever, because fever may be absent in some of these patients because of the impaired immune response, leukocytosis. But most important thing is deteriorating liver function test, or a person who otherwise was stabilized suddenly come with one or the other complication. So high index of suspicion is one which requires to diagnose these patients with infection. Fungal infection is another common problem in these cirrhotic patients. The frequency of these infections is about 10 to 13%. Many patients can have dual infections like bacterial and fungal infection. Every patient who has an antibiotic for more than 48 to 72 hours do not respond. Please suspect fungal infection in these patients. The initial workup you all know, diagnostic paracentesis if the patient has ascites, blood cultures, urine cultures, X-ray chest, but nowadays instead of X-ray chest you can do straight away HRCT because it will give you a better idea of lower respiratory tract infection and pneumonia, which is very common. All these patients where you suspect infection, according to the hospital infection control, you should start empirical antibiotics. Identify the causative organism, including the fungal pathogen. Every step should be made to prevent the multi-organ failure. The targeted blood pressure in all these patients should be about mean arterial pressure of 60 or more than 60. If the patient has tense ascites, don't rely on CVP. If patient has a septic shock and you delay the start of antibiotic, there is a chance that mortality is going to increase. So every delay of 3 hours in starting the antibiotic, the increase in mortality is by 1.86. In fact, patient with cirrhosis presented a risk of sepsis which is 2.5 times higher than those without cirrhosis with infections. Antifungal should be considered if there is no clinical improvement. Fluid resuscitation is done. The first fluid should be an albumin. In the setting of persistent hypotension, consider using norepinephrine or vasopressin. Low dose steroid can be considered in those patients who are refractory to treatment. If criteria for refractory septic shock are met, then you can use regular low dose steroid. When there is a need for endotracheal intubation, use propofol rather than benzodiazepines for the sedations. Liver transplant should be considered in patient only if the infection is controlled, and those who are not controlled are those who are not candidate for liver transplant. They may be evaluated for end-of-life care. The spontaneous bacterial peritonitis, you all know that how to treat it. I will not go, but you have to decide antibiotic based on your assumption whether it's a community acquired or nosocomial. Similarly, for pyelonephritis, whether it's an uncomplicated or a complicated, you have to decide about the antibiotics. And similarly, in pneumonia, whether it's a community-acquired pneumonia or a hospital-acquired pneumonia, decide about the antibiotics. Similarly, in cellulitis, if it's a moderate cellulitis, it's only penicillin or ceftriaxone, but if severe and failed antibiotics, presence of sepsis, consider higher antibiotics with vancomycin. How to prevent infection in cirrhosis? So you have 3 strategies: primary prevention, secondary prevention, and tertiary prevention. So first is how to prevent the infections or reinfections. So universal immunization against hepatitis A, hepatitis B, immunization against influenza, pneumococcal vaccine, and in present era, COVID-19 vaccine. Then intestinal decontamination, avoid unnecessary instrumentation if it is not required, control ascites, but the most important thing is balanced nutrition and some form of exercise which is feasible. For secondary prevention, if you have patient present with infection, try to prevent organ dysfunction. This is the secondary prevention, because if there is an infection and there is an organ dysfunction, mortality and morbidity increases significantly. And tertiary intervention is give them a good organ support if they have come with an organ failure, like renal replacement therapy, vasopressor therapy, and mechanical ventilation. The multi-drug resistant infection in cirrhosis is a major problem these days. Worldwide, it is the most serious concern. In series across Europe, North America, and Asia, about 10 to 45% of patients with spontaneous bacterial peritonitis were infected with organisms which were resistant to first-line, third-generation cephalosporin. The most frequent infection are healthcare infections and hospital-acquired infection. They deteriorate the liver function, and cirrhotic patients should be monitored closely for infection, especially those with child B and child C cirrhosis. Ladies and gentlemen, I welcome you and I request all of you to join us for the next National Conference of Society of Gastrointestinal Endoscopy of India, which is going to be held at Indore from July 7th to July 9th. So please do join us. This will be a fascinating event with many innovative endoscopic procedure which will be shown live with debates and lot of lectures from keynote speakers across the globe. Thank you very much. If there are any questions, I'll be happy to answer them. Thank you.
Thank you, sir. Thank you, Dr. Jain. Any question and comments? We have got one question. How do you find this association of tuberculosis in cirrhotic patient, and how do you manage?
Okay, so we have some experience of treating tuberculosis in cirrhotic patients, maybe about, we had in last 3 years, maybe about 7-8 patients. So those patients where you have a high index of suspicion, and are those patients who have come with gradual deterioration or a sudden deterioration in liver functions, and you try to find out the infections. The most important thing is, if they have a pleural effusion, look for tubercular pleural effusion. If they have an ascites, and if it is a low SAG ascites, you just look at other parameters to diagnose them tuberculosis. The third important investigation is HRCT, because they may have a CT scan, some infection is here and there. But it is always a high index of suspicion where you have ruled out other possible infections like bacterial infection, patient has a normal urine culture is normal, blood culture is normal, patient has pleural effusion, patient has ascites, it's a high protein, low SAG ascites, suspect tuberculosis, and if your other investigations support you, even if not, and your suspicion, clinical suspicion is high, empirically you can start treating them with 2 drugs which are bactericidal and 1 bacteriostatic drug. Avoid starting pyrazinamide in these patients, but Isonex and rifampicin can be given safely even in full-blown cirrhotic patients.
Thank you, sir. Any question and comments, please?
In the interest of time, we close this session, and thank you, Dr. Ajay Jain, for elaborative talk.
Thank you, sir.